Thank you. Great. All right. Perfect. Okay. So here we go. I wanted to give you guys a talk about complications following adult spinal deformity, talk about the definition, talk about some incidents, and talk about some of the work that I and my collaborators at ISSG have done looking at complications, trying to understand the impact on those complications on our patients, and which is really probably the most important question. So here are my disclosures. I don't have any financial interest with anybody regarding this particular subject. So when we think about deformity surgery, we know that it has high risk of complications. The complications are frequent, and Steve Glassman in 2007 looked at complication rates and found them to be around 40%, just a huge number. And I think we really have to think about what is a complication and how do we define it, because we can make the complication rates go up or go down based on our level of scrutiny. And so when we think about a complication, the way I define it is a disease or condition that happens in addition to that other disease that makes it more difficult to treat. And we can come up with a list of those complications, and here's that list that we use in the ISSG, and it really covers everything under the sun. It's from UTI to dural tears to paralysis to bowel and bladder deficits. And you might imagine those complications are all exceedingly different. Steve Glassman was really the first one to think about what a complication was and then how it impacted our patients. And he wrote this paper that found that major and minor complications didn't actually affect the HRQL improvements, except for this SF12 and major complications year after surgery. And he really never liked this paper because he said, it just doesn't feel right and it doesn't feel true. I know that the complications that my patients have affect my patients and affects them deeply. I just wasn't able to prove it with this data. And what he thought was ultimately was that the outcome instruments that we use aren't sensitive enough to detect a difference. And maybe also additionally that as we get further away from that complication, if you have a heart attack and you survive that heart attack, that maybe it is less impactful for you a year after surgery. And so with that, the key part to complication management is not to have it in the first place. And so medical optimization, cardiac, pulmonary, nutritional, metabolic, and bone health are critical. And, the Seattle group has really done a wonderful job, and JC can talk about that and the work he's done with Sethi, looking at this team approach and understanding how to treat patients appropriately. And then Tyler Koski, of course, in Chicago, has really done a wonderful job of developing teams. And I think with the advent of these papers, really all of us at large deformity centers have followed suit. We have teams that we work together to help us mitigate the complications and really do this pre-optimization of our patients to make sure that we have the patients in the best possible place before we take them in the operating room and do all that tremendous damage. When we look at complications, there is a huge incidence. And so we did some work here with Justin Smith. We looked at complications. We followed 250 patients with 2-year follow-up and looked at all their complications. And here's what that list looks like. And you can see implant, radiographic, neurologic, operative, cardiopulmonary infection risks were all the most impactful. And at the end of the day, this was kind of the final conclusion, is that 70% of patients have either a major or a minor complication in the perioperative or in that delayed greater than 6-week perioperative period. And if we look a little bit more carefully about what those complications are, they're all the things that we've been talking about today. And so there are rod fractures and implant prominence. Those are the most common implant complications. Radiographic, again, PJK and pseudoarthrosis with some adjacent segment disease. These are the common problems that we face. Neurologic, we talked about this already as well. Radiculopathy, motor, and sensory deficits, particularly in that early perioperative period, are significant, and we certainly worry about that for our patients. Operative, we talk about bleeding and dural tears. And then cardiopulmonary are really all these pleural effusions, arrhythmias, and cardiovascular complications that we have. So I think when you listen to that list, you say, wow, 70% complications, that's crazy. Why are we doing this? We're going out and hurting the vast majority of our patients. We should probably get a different job, or we should do it differently, right? Well, I think the answer, first of all, is we're better now than we were. and we're still striving to be better and better. I think some of this also is some self-flagellation, right? And so we walk around and we go, oh my God, that was such a terrible UTI I got. And the answer is, well, hang on a second. It was a UTI, and yes, we can count it as a complication, but I'm not sure how impactful that is for us, our patients, or the payers. When we think about complication and advancements, boy, we've done a lot of things. And so Doug just showed how we can place satellite rods. We can think about multiple points of iliac fixation. We can think about segmental fixation in inner bodies to prevent rod fracture. When we think of PJK and PJF, Bob Hart showed his classification system he's worked on a long time. And we've also thought about how we can do things better, and that has to do with better alignment parameters, better understanding of who needs alignment, where, and how, and then starting to think about tethering techniques, and could those also be helpful adjunctively. And we think about that kind of soft transition from our rigid fusion to our less rigid reciprocal changes that we see in the thoracic spine. We've talked about TXA and decreasing blood loss, and really this is now the standard for our patients. And the numbers you should really think of are 30 and 10. That ought to be your bare minimum where you start. So 30 milligrams per kilogram is a loading dose, 10 mg per kg per hour. That saturates all of the TXA binders, and that's the most effective. And as you go up from there, there was no real additive benefit to additional TXA. Deep wound infections, well, vancomycin is really the standard of care now, and so we place vancomycin fairly liberally. We're like LeBron James in the operating room, right? Kind of pound that stuff together and off we go. And so that has really made a huge difference and certainly cut down our infection rate. I think what it does is it overwhelms the system in that local environment and really helps treat those gram-positive infections. I think, like we saw looking at the pediatric population, I think if you have a neuromuscular patient, you may need to think about some tobramycin to start thinking about some gram-negative coverage as well. I think that would probably be appropriate. Well, I spent last night thinking about how I could demonstrate how we think about surgical strategy and treatment. So here's the slides I made for you. I worked tirelessly through most of the evening. And you can see that with increasing invasiveness, we have better and better outcomes. But you can see the outcomes kind of plateau, right? At some point in time, just doing more is just doing more. And with doing more, we actually increase that complication rate, and that complication rate goes up. And as we increase the complications, well, then we start impacting our outcomes. And how do we measure that, and how do we understand it? Well, part of it is that what is a major complication, right? One of my jokes with my patients is I say, you know what major surgery is? That's any surgery on me is major. Okay, we don't take any of that stuff lightly. And so a lot of it is in the eye of the beholder, right? The things that I think are major, you might not think of as major, and we might disagree on a dural tear or simple complications. Is dural tear a major complication or a minor complication? Well, I suppose it's major if we've got to take them back to the surgery. It's minor if I can close it up okay and everything's all right. It's probably someplace in between if they get a little radiculopathy and it goes away. So there's no consensus just looking at a complication, understanding it. And the severity of that complication may also be biased. And so again, like I said, anything that happens bad in me is a major complication. Maybe anything that I see happen bad in you, I might call a minor complication. And maybe if we came up with a better score, maybe we could predict our HRQL outcomes better. And that part of the issue is understanding what a major or minor complication is. There's been a lot of work in this. So CMS, this is our government payer, and so they really have placed an increased emphasis on complications. And so they will not reimburse you for any complication that happens within 30 days of the operation, because they say that was your fault, or any readmission or reoperation within 90 days, because they say that is you're responsible because that was because of your operation. And obviously that has a significant impact on bundling of payments, and starts to give us insight in how the government is thinking about how we attribute complications. The Canadians started off with SAVES. This was John Street's work, where he looked at an intervention severity scale from 1 to 6, and also a length of stay modifier. So complications that happened that then made you stay in the hospital longer were more impactful for you, more impactful for the patient, and more impactful for the payer. And so and the one thing that they noted was that if you go back and look at complications retrospectively, you missed a lot of complications. And so you really need to keep track of this longitudinally and as it's happening in front of you. AO spine and scoli risk really looked at complications and really focused on the neurologic deficits. They looked at the neurologic injury, when it happened, where it happened, and described the critical portions of that, which were really timing, intervention, and outcome. So with that, we started thinking, gosh, you know what, major and minor isn't granular enough. Then there's been some work, the Clavien-Dindo system looks at some of this and tries to recategorize it. Now, we didn't really love the Clavien-Dindo because it doesn't have a specific neurologic component that we felt that we could add easily into our system, and that probably is particularly impactful for spinal surgery. What we did is we said, boy, any complication system that we have needs to be composed of some different portions, particularly for spine. It needs to have a neurologic component. We need to know when it happens. We need to know what we did to fix it, and we need to know whether or not that complication got better. And all of those things are important pieces. And with that, we came up with this universal complication classification. We did this with the help of the ISSG, the ESSG, and the AO spine team, and we kind of looked through it and came up with a consensus statement and thoughts about how this should work. And we can break these down into their subscores, so neurologic can have all these different subscores. Then probably the most important portion of that is the motor scores, your motor function. In terms of timing, we can figure out whether or not when it happened and how it happened, or did you have to be readmitted or reoperated on. Again, critical when we think about not just HRQLs, not just how our patients are doing, but also when we think about the cost and the impact in society. The intervention subscore, where we say, what do we had to do to fix that complication? If it's a dural tear that requires a return to the operating room, that's a grade 3 intervention, in which case that's going to be severe and costly and more impactful for our patients. Whereas if we just had to watch it or throw a stitch in at the time of surgery, that really didn't cause any additional impact. We can also look at resolution, and as we know, the ultimate resolution is death. While it is not terribly impactful for our patients' outcomes, right? We can't measure it. It's kind of the ultimate resolution score. And so with that, we came up with that classification, put it all together, and this is what we currently use now to gather our information and gather our complications in our databases when we're studying patients and studying how people are doing. We validated the score, so we looked at this identification and classification and gave everyone some random cases to then score and develop. 34 events happened in those 10 patients, and what we did is then had people score that, and you can see a very high accuracy level. It did go down as we got more and more granular. And there's some things that were particularly accurate, so cardiovascular events were very accurate, and maybe some of the medical complications we were less good at identifying. We also found that over time, as you started working with this classification, you got better and better at using it and understanding how to classify things appropriately. And so we found that complex complications were categorized accurately, neurodeficits were also accurate, but that surgeons with some medical knowledge really needed to be involved to help put these in perspective for us, our patients, and our payers. Well, I guess ultimately the question is, well, who cares, dude? You've been talking up there. I'm pretty sleepy because I've eaten my lunch and I haven't finished my second coffee yet. Does this system actually help us, and does it help us think about how we're taking care of our patients? And so I want to just show you some of the data that we've come up with in the last couple of years that have looked at those specific questions. And so looking at the effect of incidence and timing, and then we're also going to look on HRQLs and length of stay. And so if we look at this timing subscore, we really wanted to look and see whether or not timing and complications impacted our patients, and whether or not when a complication occurred helped us understand both what that complication was and then how it would impact our patients. And complications, not surprisingly, happened all over the board. 70% had at least one complication, but the complications and when they occurred were predictable. And by that, I mean that there were some complications that only happened early. Those are going to be the cardiopulmonary events. The first infections tended to all happen early. GI complications all happen early. While neurologic deficits, radiographic fractures, or implant failures all happen continuously over time. And with that, we were able to develop a Kaplan-Meier survival curve to get a sense about where we're seeing complications. And you can see these distinct blips that happen, in particular, 3 to 5 years after surgery. At the index is the largest, but then 3 to 5 after surgery are critical portions that we need to follow. And so don't abandon your patients after a year or 2 years if you do deformity surgery, as the complications will continue to mount over time. And maybe some of these new techniques, new metallurgy, multiple rods, PJK prevention strategies may help us. We can look at the survival analysis again here. This is just looking at specific complications of GI complications, infections, neurologic events, and then overall complications. And you can see that we get to this survival at about 30% of no complications after 5 years. If we try to figure out how that affects our patients, well, it turns out, unfortunately, that those that did worse also had worse initial outcome, scores. So if we propensity match them and make them all the same at baseline, it turns out that those that had a bigger impact or a bigger complication that occurred particularly later on, so the implant complications, neurologic complications, and PJK continue to be affected 2 years after surgery. And so if we sub-analyze for those types, they continue to give us problems and continue to affect our patients 2 years after surgery. In addition, if we start looking at complications and try to look at length of stay, what we wanted to compare is whether or not this intervention severity score would be better than major and minor in terms of predicting how long people need to stay in the hospital. And what we did is we had 480 patients with in-hospital data, and then we could grade those complications and then look at major and minor complications and compare them to see which one of those two systems would help us understand who stayed in the hospital. And interestingly, if we look at that ISSG-AO grade complication, with increasing grade, we see increasing rates of length of stay. Makes sense. The more we do, the longer the patient stays in the hospital. Conversely, it turned out that those patients that had major complications left the hospital earlier than those that had minor complications. Again, just showing you that there's so much ambiguity into what a major or minor complication is that maybe it really doesn't tell us very much about what it's doing to our patients or to the health of our patients. So again, you can see that going up and going down. And even if we look at this conditional forest plot, where we look and what is the most important impact on this, and so the higher you are, the more impactful it is. And you can see the number one is that complication intervention severity score. Major and minor complications is way down at the bottom. And so again, there are so many other things that factor into why a patient stays in the hospital, and the least important is whether or not it's a major or minor complication. Again, we kind of looked at that a couple of different ways, showing that the higher the grade, the longer the length of stay. And so, in conclusion, when you have these inverse relationships, I think we have to be careful about what that means. I hope I've convinced you of a couple things. One is that the way we classify complications and discuss them with ourselves and our patients and our payers, I think is critically important, and we need to be very specific about how we do that, and that not all complications are created equal for us, our patients, our payer, and so we need to be thoughtful about what are the ones that we're going to invest the most in to make sure we can prevent and that will be most impactful for them. So thanks for your attention and time.
Well, thanks, Eric.
Anybody still awake?
Yeah. There is a little postprandial tide probably going on here. But, that's great work. It's just so important. I'm reminded, I have a phrase that I use in some of my talks that says surgery is controlled injury, right? Yep. And as surgeons, you a lot of times lose sight of that because it's just what we do. But it is, you can't, that's what it is. We're cutting people open. It is injury, so. Did you come away with, and I think you may have said it, but what are the 2 or 3 most impactful complications in adult spine surgery?
Yeah, so I think it's a great question, and the answer is it depends. And so it depends on the outcome metric you're looking at. So what is the most costly complication? The answer is revision surgery. That is for sure the biggest deal. The biggest deal for our patients is what happened most recently to them. And so if you take a look and and see what they did immediately after surgery, the answer is going to be the most proximate complication. The neurologic complication events are a huge deal early on. Luckily for us, the neurologic events typically get better with time. People neurologically improve and are able to make, in most cases, a substantial recovery. And only the minority of patients, usually 2 to 3%, like we saw, have any long-lasting neurologic deficits. I think the things that we need to think about as we, as a society, think about how we're treating these patients is we need durable results with minimal long-term complications. So I think that what we should spend our time and money and focus on are going to be in the initial surgery, making it safer, so neurologic events. I'm still find myself disappointed sometimes in the neuromonitoring and its ability to accurately demonstrate whether or not I have or have not had a neurologic event. I don't like the post-operative exam should not be the time I figured that out. I don't understand why we're not better. We have to get better than that. So I'd love to see some investment from industry or the like to fix that problem. And then the other things are the long-term durability. Rod fractures, pseudoarthrosis, and PJK, we need to invest time, energy, effort to make sure we minimize those. I think we've gotten a lot better, and so I think with the advent of understanding the patient-specific parameters, being more thoughtful about how we do that, and then some of these adjunctive things like tethers, I think we really have made a difference there. It's just, but we still need to do better. JC?
Yeah, thank you, Eric. That's a really nice summation of the issues that face our patients. And it's interesting as you put up the CMS guidelines, right? I mean, it sort of works against some of the things that we all as surgeons who do deformity surgery believe, in that you're willing to accept short-term complications for better long-term gain. You know, we've talked a lot about osteotomies today. You may be willing to accept a weakness in a patient post-op with an osteotomy that you figure will improve if that will provide a better long-term outcome. And that is going to work against you in terms of any reimbursement or quality measure, which is typically at the 30 to 90-day point. And any thoughts about how we address that?
Yeah, it's a great, you know, I think it'll be a real challenge in the United States. And part of it is how our insurance system is set up. If you're under 65, you have private insurance. If you're over 65, then you have this public Medicare or governmental insurance, at least as your primary typically. You might have a secondary one as well. But the problem with that is that people change their insurance so quickly, the insurance companies really don't care about long-term outcomes. I'm going to probably get assassinated on the way home now. But I think what they care about is the one-year outcome, because they know that 50% of people change their insurance every single year, and you change it because of your job or because of your health status or because you want the cheapest insurance plan rather than the one that gives you the most flexibility. And so I think that some of this is going to have to be done in the over 65 population, because I think the government is going to say, hey, listen, we need better durability for these constructs. And so I think that's probably where it's going to be pushed first. And then I think it'll trickle down to the other insurance companies that will then mandate that. So I think that's the way it's going to go. I think this is a lot easier to do in Canada or in Europe, where they have universal health care coverage for everyone, and they are more focused on that overall, what is the spend and how do we most effectively spend our resources. I think we're a little bit behind them in the United States. Again, the only thing I'd say to that, even though that sounds bad, is it does also allow us to be very innovative. And so we can come up with solutions that may solve these issues with using more expensive metals that maybe are worth it, or more expensive techniques that maybe are worth it. And so that ability to do that, I think, is also critically important for us and as we think about our careers and our patients.
I think there's some, the healthcare providers also have some bizarre motivations at times too. And, for a hospital, doing a second surgery on a patient more than 90 days later, well, we're going to get paid anyway, right? So not to say that drives behavior, but it certainly doesn't help. And I don't know because you guys were kind of leaders in population health approaches, which finally kind of turns that motivation on its head. Is that still going forward at VM, or how is that done?
Well, we do have sort of our warranty center of excellence component. However, the difficulty in there is that it is still an insurance-based or job-based insurance. And so our ability to have reliable long-term follow-up is still limited. And primarily that was focused on, can we limit the 30 to 90-day complications by protocols, algorithms, et cetera, rather than a durable long-term outcome.
And it needs decent data, which this starts maybe to make a contribution, but bundles for spine surgery, I think, kind of fell on its face. Bundles for total joint, where it's much more predictable, much more the same thing every time, turned out to be successful, I think, in a lot of centers, but I'm not sure.
Yeah, no, I don't know. I'm not sure I have much to add other than, we certainly, I think the difference is, I think JC said it nicely. I think we have to continue to be physicians and surgeons that take care of our patients agnostic of their insurance, and we see them for a long period of time. We need to follow them out clearly to at least 5 years before we're going to see all the rod fractures that can and will occur and that will need and may potentially need an additional surgery. And I think at the end of the day, it's our job as physicians to push back against the insurance companies and our hospital systems and make sure that we continue to advocate for our patients. And I think that's why we do the job we do, right? That's the nobleness of it all.
That's a great closure, great
right.
sentiment. Thanks.